can see the P53 aberrant in the MMRP, it has half of these patients are HER2, and that will be captured. And we are talking about 2+ and 3+, and if we take 1+, probably we will have much larger population. And I think that these patients will be taken over by drugs like TDXD, the ADCs for HER2. When it comes to the NSMP population, 54% of the population, where we don't see, or we see only a very modest effect of immune checkpoint inhibitors. We only have data from one trial, that's Ruby trial. We have to see on other trials as well. If that is true, probably we have to think on and we are already thinking on other lines. There is a phase 3 trial going on in this population, the the P53 wild type with selinexor, naftamadlin, another trial. And we are trying to push to get trials done with CDK4/6 inhibitors with endocrine therapy. So I think we have a lot to do here in the NSMP population. So I think this is, we are in the limbo, we're in the transient stage where we are thinking about only about immune checkpoint inhibitors. In years to come, we will completely change our management when we see the results of these new drugs coming in. This PMMR, which I call Jurassic Park, will have small pieces, and every small piece will be treated with different drugs.
Interesting. It sounds like the Embattled trial, Matt.
That's right. It sounds a lot like the trial
remember that
years ago. Yes.
Yeah.
I think one of the things to call out, I think, and part of knowing these data for a few months, I've been so excited to have everybody see this, what Mansoor so lovely presented at ESMO. But we don't see POLE much at all outside the uterus. It's mostly a uterine problem. And we're going to use POLE to help us decide who doesn't need adjuvant therapy, because those POLE tumors can look ugly, but they rarely escape. So they rarely end up in systemic disease trials. So you almost can ignore POLE when it comes to treating systemic disease. You still should check for it, mind you, but it's not very common. And I think people get frustrated. They say, well, I've looked for 100 patients. I haven't found it yet. Well, it's only in about 1 to 2% of our systemic therapy patients. And as Mansoor mentioned, this NSMP group is our biggest challenge. To figure out how to treat this. Is it hormonal? Should they be treated like ER-positive breast cancer? And they look a lot like ER-positive breast cancer in some ways. So I think we can learn a lot from other tumors. And there are P53 aberrant tumors are very similar to triple-negative breast. And we can learn something there. And it's interesting. It's probably more like triple-negative breast than it is like ovarian cancer. It tends to respond to checkpoint, where ovarian cancer doesn't in this situation, but triple-negative breast does. So I think there's so many interesting things that we're going to use to help our patients in the next few years and continue to develop all this better.
Yeah, I just want to commend Mansoor. These are beautiful slides. I love the colorful pattern. And then this NSMP group, just like you said, great candidates for the export study, to continue to move that needle forward. And here's your data regarding the molecular subgroups with this significant PFS benefit in the P53 mutant group and the DMMR group, which is a no-brainer. I have to say, I'm not overly impressed with this group and NSMP, just my thoughts there. And I just want to go and show the overall survival data with really wide splits, again, in these two groups, which is really exciting. And Flora, just wanted to get any comments from you regarding the survival outcome data in these different molecular subgroups.
Mind that it persisted for the overall survival also. And I think it even tells us more that we have to start looking, especially in this immunotherapy treated patients, that we have to start looking at overall survival and how these curves flatten and how it may take a little bit for their effect to start to take. We shouldn't look too early. We shouldn't look at 12 months because we would have missed all of this, all of these great separations of the curves. So things are changing with how we treat, but also how we evaluate benefits.
But a 60% improvement in overall survival, who would have ever guessed? I mean, it's so exciting to be able to, and these are our patients that needed our help the most.
Right, which is why you're up early in the morning putting together this incredibly huge slide set. So thanks everybody. We only have a few minutes, so just want to give you all one parting last comment. But it's truly an exciting time in endometrial cancer. And thanks for letting me like hijack your Sunday morning. We saw that Mansoor gave us a little tour of his house. It's really beautiful.
Thanks.
So I'm going to let Flora go first, and then Mansoor, and then Matt, close us out with your final comments, and we can let everyone go on this beautiful Sunday. Go ahead, Flora.
Yeah, I think this is just a fantastic work that all of us have done together, working on these clinical trials. And it takes years for this to mature. But we're really, like you said, it goes so fast all of a sudden for our understanding and getting better outcomes for our patients as we subdivide them and getting them really that personalized treatment. So keep putting your patients on trial, and we keep moving science forward.
Absolutely. Mansoor, last words?
I think in this year we have completely changed the management of this disease, completely changed, starting from March, but I call it, as I wrote to Matt, this is just the tip of iceberg. We are starting to understand this disease. We have to go deeper, work a lot, look at all different aspects. We have so many patients in these trials. We can learn so much out of that. And I'm sure that in few years to come, this will be a disease. Most of these patients will be cured. And that's our goal.
And Matt?
Well, I would say from the time I started my training, nobody wanted to study endometrial cancer. It is, and now to be able to run 5 to 6 large trials across the world speaks to cooperation, team science, and we'll give Zoom some credit because we can talk to one another all across the world now. So, I mean, there are some good things that came out of COVID, and we'll call Zoom one of them, that we can all work together so much more efficiently.
The silver lining. Okay. The future is bright. It's so exciting right now. We have the IGCS meeting in Korea. We'll be presenting the GOG 258 data. So I don't know, Matt, radiation may still have a role. You'll have to see. I love the fact that you all were very cautious about you and how you interpreted this data, because these are ancillary findings and many of them are not pre-specified, but some of them are, and it's very hypothesis generating. And I just also want to echo, we have SGO winter meeting in 2024, SGO annual meeting in 2024, the power of shared purpose, how we all got on this call today, and really transforming gynecologic cancer care so our patients can have longer and better lives. So thank you all. Big heart. I can't believe you let me do this to you on a Sunday morning, and you're fantastic individuals for all the great work you're doing. Bye.
Thank you so much.
See you all in Seoul, Korea. Thank you. Safe travel.
Safe travel.